Friends, welcome to my workplace at Ranaghat, West Bengal, India. In this video, we are going to see the stop and chop technique of phacoemulsification. This is a video for beginner surgeons who have done some cases with divide and conquer technique, now want to try the stop and chop technique of phacoemulsification. By this time the main incision has been made, and now this is a side port on the left side of the main incision, and this is another side port on the right side of the main incision. An air bubble is injected into the anterior chamber. Beneath this air bubble, trypan blue dye is directed towards the capsule. It is not directed towards the angle of the anterior chamber. So, go into the anterior chamber and apply the dye on the anterior capsule. Here it goes. And the dye should touch all parts of the anterior capsule. This is a bit of adrenaline. It's a good habit to wash the dye out of the anterior chamber. Wash the excess dye. Visibility becomes better if we wash the dye out. And now the anterior chamber is filled up with 2% hydroxypropyl methyl cellulose. Here it goes. Any air bubble in the anterior chamber is replaced by the visco. The visco has been applied over the corneal epithelium. It will improve visibility. And now rhexis is being done with a needle. In this case, this is a 26 gauge bend needle, bent to make a disposable cystotome, and this cystotome is being used to do this continuous curvilinear capsulorhexis. Care should be taken to do an adequate sized rhexis of about 5 to 5.5 millimeter. And now hydrodissection is to be done. Before injecting any fluid, some visco is expressed out, and then BSS or ringer lactate is injected just under the anterior capsular rim. Then the nucleus is tapped, and then the nucleus is rotated. And now visco is injected into the anterior chamber, and then now is the time to introduce the phaco handpiece. The exposed part of the tip should be this much. The phaco needle goes with its bevel down. Don't push it like this. Enter into the tunnel and go downward, and then remove some superficial cortical lens matter. This will also improve visibility. And now the handpiece is turned with the help of the left hand. and the irrigating and aspirating tubes are arranged in such a way that there should not be any kink anywhere. And now a trench is made. At this time the ultrasonic energy in this case is 60%, flow rate is 25, and vacuum is 80 millimeter of mercury. A tunnel is made very carefully, and the central part becomes deep, periphery not so deep. You can see faint red glow, and when it is seen, the two instruments go to the floor of the trench, opposite forces are applied, and the nucleus is divided into two halves. Now each heminucleus is held not superficially, it is held in the middle, and very nicely it is held with vacuum, and the chopper is used to divide the heminucleus into two fragments. Then each nuclear fragment is brought at the center of the anterior chamber, and it is emulsified. Again, the other heminucleus is chopped into two pieces, and then each nuclear piece is emulsified with ultrasonic energy. Then this is the last piece. At this time the vacuum is reduced to about 300 and flow rate to about 30. During emulsification of the other pieces, the flow rate was 400, the vacuum was 400, and flow rate was 40 ml per minute. And now the cortex is to be removed. I am using a 23 gauge Simcoe cannula to remove the cortex. We could use bimanual irrigation aspiration, but beginners are more comfortable with Simcoe because they have done a lot of SICs, and this instrument is well known to them. So we can remove the cortex by this 23 gauge Simcoe cannula. But all instruments have to be, we have to learn how to use all instruments. Bimanual irrigation aspiration also must be learned. There is some fibers sticking there, so it is being removed by the 23 gauge Simcoe. And now, beginners must implant the intraocular lens, filling up the antechamber and capsular bag with 2% hydroxypropyl methyl cellulose or some kind of viscoelastic substance. The main wound is enlarged to by about 0.2 mm. The main wound size is about 3 mm now. And now here goes the intraocular lens. This is a single piece monofocal intraocular lens. Yes, both the haptics have gone into the capsular bag. The optic is overlapped all around by a thin rim of anterior capsule, and this is good. The lens will never tilt if it is overlapped all around by the anterior capsular rim. Now, with the help of the Simcoe cannula, most of the viscoelastic substance can be removed. First, we irrigate the antechamber, then irrigate the capsular bag, and then aspirate for some time. And now I'm going to use the bimanual irrigation aspiration cannulae to remove rest of the viscoelastic substance. Beginners should use the irrigation through the side port, not through the main wound, because the beginners will not be able to maintain the antechamber depth if you go through the main wound. The irrigation and aspiration is used together for a few seconds. Now, moxifloxacin is injected into the anterior chamber. Then the side port is closed by hydrating corneal stroma with BSS. And now, a final lavage of the anterior chamber is done with 23 gauge Simcoe and BSS. At this time, a gentle stream of BSS goes towards the corneal endothelium. Any viscose sticking to the corneal endothelium comes out. The antechamber is nicely formed. All the wounds are checked. There should not be any leakage from any side, and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. After doing some cases with divide and conquer technique, try this technique and learn how to hold a heminucleus with vacuum and chop it.